Hello, we will talk about the pathobiology of the apical periodontitis. We first must know what are the structures surrounding the apex that affect the response of the immune system to the bacterial invasion. We know that we have the cementum, the periodontal ligament, and the alveolar bone. The cementum has many growth factors that are released under certain conditions, and they are associated with cementoblast proliferation and the wound healing. The periodontal ligament actually has many cells that include the osteoblast, the fibroblast, macrophages, cementoblast, and the stem cells. These epithelial cells that are called the Hertwig epithelial root sheath are said to be the source of the radicular cyst formation when they are stimulated by inflammation. And the periodontal ligament is highly vasculated. The bone is composed of a bone matrix, growth factors, and the osteoblast that helps in the bone healing when there is a wound formation. As we said in the previous chapter, that the bacteria the biofilm stays inside the root canal system because it becomes protected from the host defenses and the antibiotic therapy, because there is lack in the blood circulation in the root canal system. But these bacteria release their toxins like the lipopolysaccharides or the lipoteic acid that cause an inflammation in the periradicular area, even though they are staying in the canal. So the LPS and LTA are recognized by special receptors on the immune cells that are called the PAMs. So they are activated by when vasodilation happens, and they came to the site and produce an inflammation and try to kill and clean the area. So this process, we see it under in the radiograph as a radiolucency around the apical area and a dilation of the periodontal ligament, where we call this phase the apical inflammation. But in some cases, when the bacteria reaches to the radicular area and become physically presented there, we get an true infection, and the case becomes acute, which means that we have now an abscess and a draining sinus tract and extraradicular endodontic infection. The moment bacteria reaches to the periradicular tissue, it will always be killed by the host defense mechanisms. So when we remove the infection in the root canal system, the immunity can deal with the infection around the apex in the periradicular area. And we usually do not need to prescribe any antimicrobial therapy. We prescribe to the patient antibiotics in two cases: when there is a suppression in the immunity, when the patient is taking, for example, radio X-ray therapy, or the patient has diabetes, an uncontrolled one, or there is some cardiac pulp implantation, and the other case when the infection is associated with systemic symptoms like fever and tiredness. Here the author is saying that Periradicular inflammation can happen even though the pulp inside is not fully necrotic. And we can see here in the black arrow, that the pulp here is vital, even though the toxins has reached to the periradicular area and caused an inflammation. Also, some bone resorption is present in the area of the infection. The nervous system is important in the inflammation process because when these neuropeptides are released from the stimulation of the irritants, the nerve fibers cause vasodilation, and for the immune cells to come to the area, like the neutrophils, the macrophages, and the lymphocytes. Also, the neuropeptides, they regulate the bone resorption and the wound healing. So here we can see that the neurotransmitters affected the blood vessels and caused increased their permeability and causes them to increase their vasodilation. So all of these components, the immune components, were present in the area and started fighting the infection present and the bacteria. Some apical periodontitis can be symptomatic in the acute phase and asymptomatic in the chronic phase. And the acute phase of the periradicular periodontitis begins with a furious battle between the highly virulent pathogens and the army of neutrophilic leukocytes. The pathogenic produces massive toxins to kill the neutrophils, and as neutrophils attack the pathogens, they secrete lysosomal enzymes that digest not only the dead cells but also some live ones. Many neutrophils die fighting against the pathogens. The resulting purulent exudate is poorly oxygenated and has a low pH. So these are the components of the abscess. Abscess can be associated with acute apical periodontitis or with the chronic ones. But when we see this yellowish fluid, we must know that this is the result of a war that has happened between the immune cells and the pathogens. Now this is important. When this acute inflammatory response happens and the patient is suffering from high pain symptoms, the case can get into three directions. First, if there was the irritant is immediately eliminated by root canal therapy, the case will reduce, which means that we will go back to the normal periapical tissues, and the symptoms will be relieved. In the second case, when an abscess formation is present, if massive invasion of periapical tissue by highly pyogenic pathogens occur. So we get an abscess in the area. The third direction is the progression to the coronal apical inflammations if the irritants continue to persist and the patient in the start, for example, neglected the therapy and was only taking inflammatory and the anti-inflammatory medications, so the case becomes chronic. This is chronic apical inflammation can get back to the acute phase, but with higher virulence, which means that if the bacterial virulence and the numbers of the pathogen overwhelm the host's defense, the abscess may break through the cortical bone, the periosteum, and the oral mucosa or facial skin, to develop an intraocular or extraocular draining sinus tract. Sometimes the uncontrolled abscess may spread along the facial planes of the face and neck to develop a serious cellulitis. This is what is the last thing of the infection. But if this abscess can be resorbed by the periapical tissue in the previous stages when we remove the infection from the canal in step 2. But if we proceeded to step 3 and after a chronic phase there was a change in the host's defense or the bacterial virulence, this pus will spread through these spaces and causes a serious cellulitis. The chronic apical periodontitis is what we call granuloma. The cholesterol crystals are usually found in the apical periodontitis of the chronic phase, or in a radicular cyst. In both of them, we can see these cholesterol crystals. Also with bone resorption in the apical periodontitis, the chronic phase. The chronic apical periodontitis lesion with abscess formation always show a draining sinus tract. Occasionally, the sinus tract from an apical abscess may drain along the root surface and opens into the gingival sulcus. This leads to the development of a deep, narrow 𝐨 pocket that often mimics a periodontal pocket or a vertical root fracture. So we must take the medical history of the tooth. Now let's talk about the cyst formation. It is believed that the radicular cyst is likely formed by inflammatory proliferation of epithelial cell rests in the inflamed periodontal ligament in chronic apical periodontitis lesion. There are three theories regarding the formation of the apical cyst. The first one is the nutritional deficiency theory that assumes that when islands of epithelium keep growing, the central cells of the epithelial islands will move farther away from their source of nutritional supply and undergo necrosis, degeneration. The products accumulated attract neutrophils and granulocytes into the necrotic area. Then microcavities are formed and the cyst cavity lined by a stratified squamous epithelial. The second theory is the abscess theory that says that when an abscess is formed in connective tissue, epithelial cells line the abscess cavity because of the inherent tendency to cover exposed connective tissue surface, which means that the cyst is protecting the adjacent connective tissue from the abscess formation. The third one is the theory of the merging of epithelial strands, which says that the epithelial tissue is proliferating in strands in all directions to form a sphere-like structure composed of a fibrovascular connective tissue with varying degree of inflammatory cell trapped. Then these gradually lack the blood supply and becomes a cyst cavity. Regardless of how a radicular cyst is formed, the main reason is that causes this proliferating of the epithelial cell is inflammation. We must differentiate between a cyst that is the source of it is an inflammatory, and it is the growth factor stimulate its growth and the cytokines, and between the odontogenic keratocyte and the calcifying odontogenic cyst, which means the other lesions that grow by themselves without the stimulation of the growth factor. Inflammation actually is the first step of the wound healing, which means that the immune cells come to the area trying to clean it from any bacterial and pathogens that are present in order for the mechanism of healing and the proliferating of the other tissues, the building tissues, to take place. So inflammation is regarded as the first step in the wound healing process. And it is actually a well and really sophisticated process, and it appears to be a programmed event, which means that every cell knows when to come, where to come, when to stop, how to go, and there is a communication and a connection between the 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 receptors, the cytokines, the signals, the nervous system, the immune system, the building mechanism that of the cells that are responsible for that. So it is actually a highly sophisticated process. Now the author is answering a so contradicted topic, that is, do apical periodontitis cyst heal after doing a normal non-surgical treatment of the canal? And he is saying that there is no study of wound healing of apical periodontitis lesions with cyst formation after non-surgical root canal therapy exists in the literature, which means the answer is no. The cyst cannot be healed by normal root canal therapy, and a surgical approach is more convenient. Also, there is a question, which is faster regarding the healing? And the periapical wound after an endodontic surgery is faster, or a non-surgical endodontic therapy? The answer is the surgical approach is faster in the healing, because we are removing the irritants surgically without relying on the immune process of the macrophages and the bacterial killing cleanup mechanism. But we know that the surgical treatment may result in a more rapid periapical bone healing, but also may imply a higher risk of late failure compared to non-surgical endodontic therapy. And endodontic surgery is more invasive. I believe that it is everything for this is a differentiation between the pocket cyst and the true cyst. That pocket cyst, which has a direction connection between the canal, may heal doing this the endodontic treatment, but apical true cyst need a surgical approach. And lesions that do not heal, we may suspect the new neoplastic lesions like the odontogenic keratocyte, or that, which means that after we are doing the root canal treatment, a true cyst maintains its shape, maintains its size, but a neoplastic lesion grows by its own and will increase its size by time. So doing a follow-up after a root canal treatment is mandatory to know that what type of lesion we are dealing with. Is it a granuloma? Is it a pocket cyst? Is it a true cyst, or a neoplastic lesion? I think that's everything for today. See you soon. Epithelial cell rests of malleces are present in normal periodontal ligament, but can be stimulated to proliferate in apical periodontitis and form the radicular cysts in certain apical periodontitis lesions. The pocket cysts may heal after non-surgical root canal therapy. Apical true cysts are less likely to heal after non-surgical root canal therapy because of their self-sustaining nature. Surgical intervention is necessary. Acute apical periodontitis can develop in three paths. If irritants are immediately eliminated by root canal therapy, healing occurs. Abscess formation if massive invasion of periapical tissues by highly pyogenic pathogens occurs. Progression to chronic apical inflammation if irritants continue to persist, which is called granuloma. However, if bacteria virulence and numbers of pathogen overwhelm the host's defense, the abscess may break through the cortical bone periosteum and oral mucosa or facial skin to develop an intraocular or extraocular draining sinus tract. Sometimes the uncontrolled abscess may spread along the facial planes of the face and neck to develop serious cellulitis, which means that the chronic phase returns to an acute periodontitis. Periodontitis lesions with abscess formation or draining sinus tract heal satisfactorily after non-surgical root canal treatment without the need for systemic antimicrobial therapy. Bacteria are usually not present in the periapical tissue, but in the root canal system they are preserved. Except in certain types of apical periodontitis associated with abscess formation or with a draining sinus tract or extraradicular endodontic infection.